Ready?
We are live and ready to go.
Okay, ready? We're on. Okay, welcome to Senate Finance Committee today on the 17th of February. We have on the calendar, we've got a total of 8 bills, and I'm going to give you everybody the order right now. We're going to start. First bill is going to be Senate Bill 422, Senator Salling. Second bill is Senator Eckert, which is Senate Bill 543. Third bill is Senate Bill 567 from the Administration Bill, President of the Senate. Number 4, also Administration Bill, Senate Bill 570. Number 5 is Senator Pinsky's bill, Senate Bill 522. Number 6 will be Senate Bill 557, introduced by Senator Young. Number 7 is Senate Bill 552, also Senator Young. And then the final bill of the day will be Senate Bill 513, which is Senator Feldman. The rules of the Finance Committee are as follows. The sponsor of the bill gets unlimited time. And if the sponsor brings any supporting witnesses, they get to designate somebody to speak for 5 minutes. Everybody after that's limited to 2.5 minutes. And so that's the basic ground rules for the Finance Committee. And with that, I'm told that we have a quorum, and we are going to start with Senate Bill 422, Senator Salling on Senate Bill 422. And Senator, you are the only witness for your own bill, so there are no designated witnesses. So it's all yours. You've got unlimited time.
Thank you, Mr. Vice Chair and Committee of Finance. I want to thank you for this opportunity to testify in favor of this bill, which is Senate Bill 422. We are here today to discuss the bill that I believe was on a road to be favorable in report from the committee, but it got halted back because of COVID. I want to help stop charging vehicles of tolls that merely are going from the Dundalk Port to Trayport Atlantic because they don't go over the Francis Scott Key Bridge. There's just a few things that I'd like to draw to your attention. First is the direct attention that I think I gave you all a document, and the document kind of speaks for itself. It has pictures where the bridge is, and it shows the gantries. They're labeled number 1, and number 1 is the new video toll gantry it was just put in place for toll vehicles as they enter and exit the Key Bridge. Gantry 2 is also a new separate video toll gantry that has been constructed for toll vehicles that do not exit or enter the bridge, but do take a direct route from the Dundalk, which is Dundalk Port, to Trayport Atlantic, and use just the access road that circles underneath the bridge. The Gantry 3 is the old gantry, which has been demolished, and it's no longer used there. Hopefully that gives kind of a picture of what we're talking about. Secondly, I want to draw your attention to Trayport's written testimony, especially in the bold language that it gave. They were told by the Maryland Department of Transportation that there would be discussions regarding the toll issues, but those discussions, they never happened. And again, we're here to ask for your help. I thought we could have a chance to talk about it, since they were demoing the booths down. They took them all down, and the new video gantries will possibly be put on the opposite side. Basically, if those gantries and those new ones, they're electronic. If they were put on the opposite side, I wouldn't be here today. We wouldn't need a bill. But they are, and it's caused problems. And again, nothing other was done but then that, because they constructed those things in place, those new gantries, to go across the road for the vehicles going from Trade Point to the Dunluck Port. And these gantries were never there before, the new ones that they put. The vehicles traveling from the port down Broning Highway onto Authority Drive, which circles the Francis Scott Key Bridge and then enters 695 North. That was where the new gantry tolls, number 2, you can see it, is in place. In 2016, we brought the bill and we were told that we would be able to expense, because there were old gantries, or old toll gantries, was to cost at least $3 million to construct. And they were going to put wall bypasses around the old gantries. So that was back in 2017 where the bill was presented again. During the hearings of both the Senate and the House, we were told several things by MDTA. First, we were told that the bill was premature and the subject of toll gantry locations would be better discussed in 2019 because of the new electronic tolling contract would be in place, which could potentially involve more exiting toll plazas. Second, the hearing in the House, the following question was asked. Let's suppose that the governor was to give you a blank check and use general funds and deconstruct the toll facilities that exist now. And construction of a toll facility on the other side of the bridge, which means then literally people who pay the toll will be crossing over and using the bridge. If we were to enact a solution like that, would that kind of solution violate the bond? And they said, no, it would not. So yet here we are now several years later, and the MTA has implemented the new contract and constructed the new gantries and added another one underneath. So the port or Trade Point, which they go underneath this gantry and not over the bridge, they have to pay. So, it kind of blows me away because we just didn't have the opportunity to talk about this. This bill would do exactly what is necessary and what we asked from the very beginning, to making sure that these trucks, which are some independent trucks that are trying to make a living and going back and forth from point A, which is the port, to point B, which is to Trade Point. Not now, I emphasize it, not going over the bridge and making them pay this toll. I think it's ridiculous. If they would have put it on the opposite side, I wouldn't be here today. So I appreciate this opportunity. And if you have any questions, I'm more than happy to answer them. Thank you.
Okay, Senator, thank you for your testimony. I see Senator Bidle and Senator Hershey. Senator Bidle.
Thank you, Mr. Vice Chairman. And Senator Sandling, thank you for this bill again. I was in the House chairing transportation when we had it in 2016, 2017. And help me remember. I remember Maryland Transportation Authority telling us when they constructed the new gantries that they would clear up this problem with the trucks paying for a toll for a facility they weren't using. Is that how you remember that?
Well, they were trying to work that out. Yeah, they were trying to work out a way where they can, because the trucks were coming back and forth constantly to that route. But then, after that, they said the gantries would be in the opposite side of the bridge, would be no problem. So yeah, yes.
And so are these big trucks still driving through the neighborhood to avoid the tolls? Because that was a big issue that we were trying to.
That is a big issue. And some of them are. They're going across areas where they have schools, where there's a community college, homes, businesses, and that's how they avoid doing that. And we try to avoid that altogether, as you know.
Yeah. Well, thank you for the bill.
Thank you.
Okay, Senator Hershey.
Thank you, Mr. Vice Chair. And Senator Bidle, I'll agree. That is the way I remember it as well, too, when we had it in the Senate. And I'll be honest, I have a very similar bill that will be before this committee next week, dealing with the toll plaza that is on I-95 near the Tidings Bridge that leads into Cecil County. And I support Senator Salling on this because we have brought these situations up to MDTA several times, either through our normal means of communications with the Department of Transportation, or through bills, or through, just community output as far as the concerns of what's going on. And we were always been told that they weren't going to make any major changes to this until all electronic tolling comes along. And that's exactly where we are right now. We finally have gotten to that point where they're making that transition from toll plazas to all electronic tolling. And the reality is they can put those gantries wherever they want at this time. And we've seen that on the Chesapeake Bay. For everybody that's crossed over the bridge lately, the toll plaza no longer exists. The gantries are now in Queen Anne's County side. And they made that determination on their own. They could have very easily made that same type of determination that Senator Salling is speaking about and put it on the other side as well, or at least could have had, communication, conversation with us on what was going on. So, I hate to legislate the Department of Transportation on these types of things, but it's come time that we've heard from them over and over again that they were going to solve these problems at the appropriate time when they went to all electronic tolling, and they've ignored the request of many of us that represent these areas. And, if passing legislation is what gets their attention and gets these gantries put into the right place, then I think that we need to move forward with that. So
Okay.
I support you, Senator Salling.
I guess
Thank
that
you.
wasn't a question, more of a comment. Any other?
My question, Senator Feldman, and I know it's been said many times before, but where is MDTA on these hearings? Again, they throw in a letter to us that's very vague. You have the opportunity now with this Zoom conferences that we've had, that they can sit in their office. They don't have to come down to Annapolis. So my question would be simply, where is MDTA on these important issues that affect our communities?
Okay, so if they're out there watching this hearing, I guess you just delivered a message to them virtually. That's good. Okay,
appreciate that.
any additional questions for the sponsor? Okay, seeing none, that concludes the bill hearing on Senate Bill 422. We're going to now move
Thank you.
Senator Eckert, Senate Bill 543. Senator Eckert, you have unlimited time.
Unlimited time. Oh my goodness. Thank you very
Yes.
much, Mr.
Don't abuse it.
Vice Chair and Madam Chair and the rest of the distinguished members of the Senate Finance Committee. Thank you so much for the opportunity to be before you today, Senator Addie Eckert, on behalf of Senate Bill 543, Insurance Health Care Sharing Ministries exemptions. This bill comes to you, and I must say, on full disclosure, this is a bill that we thought we would have had all worked out to bring before you. So we could get a clear, get some clarification on the criteria that distinguish the health sharing ministries from an insurance product, because I think that's the crux of what has happened here over the years. There's been some consumer confusion. Let me step back in history for you. I've been involved with the health sharing ministries for probably some 25 or more years. Back in 1992, when we did small group reform, there were criteria established in the insurance code that provided a safe harbor. And at that time, it was determined that these specific criteria would really identify and distinguish the health sharing ministries in its true essence, if you will, from being mixed up and confused with an insurance product. Over the years, with the evolution of the ministry and changes that have occurred, I think there's been some testing and blurring of those criteria. And so there's been an attempt to further clarify safe harbor in the law. This bill before you adds the elements that were included under the Affordable Care Act and define the organization. I believe this is for tax code purposes. And so many of the advocates in the ministries thought that this would be a good way to clarify who they are and what they are. So the initial bill was aimed to match both the Maryland law and the federal law. Well, as we began to discuss this with all involved, including the Insurance Commission here in Maryland, it was determined that this actually further muddies the water. And from my perspective, now the bill before you kind of doesn't do what I believe all the parties involved intended it to do. So what I am recommending is, rather, after you hear a lot of the testimony, and I know you are familiar with Health Sharing Ministries, my recommendation is that we put this to a summer study, a work group with members of the industry and the insurance commissioner, and maybe yourself and some other legislators who might be interested in this, to further look at those criteria that were established in 1992, and based on the experience of what's happening around the country in regard to this, what I will call consumer confusion, we in Maryland can get clarity so that that safe harbor that existed with the Health Sharing Ministries in its true sense of the ministry be protected, and those members who have their health care provided for through that ministry can be preserved. So with that, Mr. Chairman, you will have the opportunity to hear from, I think, both sides of this issue. But that's my recommendation, that we put it to a study or a work group, or if you would like an amendment, we can bring in an amendment to do that. Or if the committee would want to do that.
And let me just say, we've spoken about this issue, and the main concern is that you've got, as I understand, about 7,000 members participating in that. They, we don't want 7,000 people having no health care, and one of the issues here. And so I think that there is some interim discussion that makes a lot of sense in the group. But that said, any questions for Senator Eckert? Yeah, Senator Augustine, and we may still get some questions, Senator, about just exactly how these operations work.
Sure.
You're assuming that we actually, I mean, I know a little bit about it, but I think some of the members may not be as familiar with it. And I don't know if Senator Augustine was going, but Senator Augustine, I'll let you do your own question.
Thank you, Vice Chair Feldman, and you're right on track. I don't have the benefit necessarily of the understanding of this, and Senator Eckert, I know that you are such a strong opponent in the behavioral health space. I'm trying to understand why some of the people who we work with, so frequently are concerned that some of these provisions may limit some access to behavioral health services for some of our folks. Can you help me understand that?
Yeah, the health chair, and I think you hear from the advocates or members of the industry directly as well. But remember that a health sharing ministry is a voluntary it's a voluntary participatory activity that members kind of join. So there is no risk, no promise to pay from anybody's perspective. It's pretty much a faith-based ministry. Folks share their expenses with each other and have them paid for by other participants in the ministry.
Okay, but would that mean then?
So there's no, from my understanding, there is no defined benefit per se or outlined. It's and the advocate, again, the members of the industry could further clarify that.
Okay, thank you. Then I'll listen to what they have to say.
Yeah, that would be good. It's an education, and I think that's part of the issue, getting his head around the ministry, the faith-based activity versus an insurance guarantee.
Okay, any other questions for Senator Eckert? And I assume some of your witnesses are going to talk about, and just for the benefit of the committee, this issue of whether this constitutes insurance or not. The MIA has a cease and desist order currently in place on these activities. It just
Some of these.
context here, so they, so this is an issue. Okay, I don't see any. We're going to go to your designated witness, Senator Eckert, Shani Trick,
Sure.
who, because she's your designated lead witness, she gets a total of 5 minutes. So Ms. Tracy, you get 5 minutes.
Good afternoon, Vice Chair Feldman and members of the Senate Finance Committee. My name is Shanae Tracy. I'm the Director of Government Affairs for Christian Care Ministry, which facilitates the healthcare sharing program MediShare. I'm testifying in support of Senate Bill 543 on behalf of the Alliance of Healthcare Sharing Ministries, which represents the majority of the healthcare sharing ministries that meet the Affordable Care Act definition. I would like to thank Senator Eckert for sponsoring this bill and ask that the members of this committee vote yes on this very important, timely legislation that harmonizes Maryland law with the Affordable Care Act's federal protection for healthcare sharing ministries and clarifies that this healthcare option is not insurance. As 501c3 charitable organizations, these ministries help individuals come together to share in health care related expenses that align with their religious values. The members themselves agree on what types of medical expenses the community will share, so long as they align with the shared biblical beliefs, their shared biblical beliefs. These communities support each other financially and spiritually through health trials, made all more acute during the pandemic and its resulting economic crisis. Without the passage of this bill, more than 7,000 Maryland residents could lose their preferred faith-based healthcare solution in the midst of the global pandemic. It didn't have to be this way. The recent change in position of the Maryland Insurance Administration's interpretation of the decades-old statute has resulted in the ministries being dragged into administrative proceedings and thousands of Marylanders not knowing if they'll have a healthcare solution going forward. The Insurance Administration's position is out of step with the Affordable Care Act, the authors of which recognize the reality that healthcare sharing ministries are not insurance companies. It's also a stark departure from prior administration's positions that these ministries comply with the statutory exemption from the insurance code. This position threatens to overturn the 40-year-old record of these Christian organizations serving Maryland residents. We stand ready and willing to work to address any concerns that the Maryland Insurance Administration and other stakeholders have. We have asked the administration for months to provide any constructive suggestions to improve the bill and have still never received any. Healthcare sharing ministries may not be the right healthcare solution for everyone, but it has been for many years and remains an important solution for thousands of Marylanders who would desire a healthcare solution that aligns with their religious beliefs. I often give an analogy about transportation. You have cars, airplanes, and trains. All are modes of transportation, but have very different operational procedures, parts, and laws. But what they all have in common is that they get people from point A to point B, regardless of how they operate. How people pay for medical expenses is the same. There are more ways to pay for medical expenses, and healthcare sharing is just another option, which operates very differently than insurance. Healthcare sharing ministries allow people to travel the world to live out their ministerial calling. Missionaries, pastors, and all members can travel anywhere with the support of their sharing community. Members have access to experimental procedures if their doctors believe it is necessary. Many sharing ministries will share in those eligible expenses. Not to mention DACA recipients. Healthcare sharing ministries serve as one of the few healthcare options available to this population, as long as they agree to our statement of faith. When you really look into healthcare sharing, you soon realize that it's just more personal, more spiritual, more flexible. There's more transparency, more community accountability and participation, and provides more prayer followed by the act of sharing. On behalf of the members of the Alliance of Healthcare Sharing Ministries and the thousands of Marylanders who rely on us to protect their healthcare, we earnestly implore this committee to vote yes on Senate Bill 543 and potentially adopt Senator Eckart's amendment for the study group. A yes vote would preserve our community's ability to share in each other's medical bills by harmonizing Maryland law with the Affordable Care Act and clearly recognizing that healthcare sharing ministries are not insurance. And that's all I have today for my testimony.
Yeah, thank you, Ms. Tracy. I do want to just, so to kind of clarify one point here is So for the 7,000 folks you just mentioned, if they're not able to participate in health care sharing ministry, I mean, are they, and then I mentioned earlier the cease and desist order, are those folks then unwilling to purchase traditional health insurance? I mean, I'm sure this question comes up, right?
Yeah.
So they just choose instead to be uninsured or not get health care.
Yeah, a lot of the time that's absolutely correct. A lot of them choose us because of their religion, their Christianity. They don't want to share in things that don't align with their faith. So many of them will might choose to be uninsured, but it really all depends on what that family needs. But what we've heard is that they choose us because of their faith, and that's just where they want their dollars going. They like to know who they're sharing with, how much they're sharing with each family, and just that accountability that they have for one another. So a lot of them may not go get traditional insurance because of they just don't believe they know where their money's going and what type of procedures they're
I
going
mean,
through.
that's a kind of a threshold question is of those 7,000, how many would go uninsured? How many would go to traditional insurance, health insurance?
Yeah.
Oh, okay. Additional questions. I see Senator Bidle and then Senator Reedy. Senator Bidle.
Thank you, Mr. Vice Chair. Thank you for your testimony, Ms. Tracy. I was just reading the MIA letter, their letter of information, as they call it, and they talk about the five things that must be met. So are all the healthcare sharing ministries 501c3s, or are some of them for profit?
The ACA defined healthcare sharing ministries are all nonprofits. 501c3 charitable organizations.
Do you have the annual audit that's performed by an independent certified public accounting firm done every year?
We do.
Is it available to the public upon request?
Absolutely.
Okay. Thank you for that. That's all.
Okay, Senator Reedy.
Thank you, Mr. Vice Chair. And Shani, thank you for your testimony.
Absolutely.
In your viewpoint, I know that we've got the MIA issue that's kind of out there on this. In your view, is that partly because there have been some bad actors that have utilized the same terminology? That I know there's a well-known case going on right now about someone who basically started something and called it something similar to a Christian ministry sharing, and then is like there's an investigation about it. It didn't happen in Maryland, but it happened somewhere else. I mean, do you think that is part of the issue that's caused the MIA to be concerned? Because I think we're seeing this in some other states where there's concern about it because of you guys have been around like what, 30, 40
years. Yep.
Right. So but most people might not know that. So could you speak to that? Is there's that issue going on?
Absolutely. So yes, sharing ministries have been around since the early 1980s. And when the ACA was passed, they specifically put in the date stamp to ensure that these sharing ministries that operate have, I guess, long-standing, that they have the ability they have a membership that's capable of sharing in those needs. So we're currently having more sharing, I call them sharing organizations that are popping up that are post 1999. And some of the departments of insurance have kind of gone after them for one, not meeting the ACA statute in regards to the date stamp. And they definitely have all the means to do that. So with the, I guess, emergence of this other healthcare sharing organization and not necessarily kind of following the same sharing operational procedures that most of the longstanding healthcare sharing ministries do have, they've run into some issues with some of the other departments of insurance. So yes, there is definitely one bad actor out there that I think all the departments of insurance are trying to get at, and they currently have the tools to do so if they implement the safe harbors that are in their states that have the.
Bad actor is not a member of your organization, and you've had no consumer complaints in Maryland anytime recently, correct?
That's correct.
And then my other question, or Mr. Chairman, maybe it's more of a statement. I'm interested in this issue. I was sort of aware of this sharing, even before I joined the committee on sort of a, tangential level. But normally we all kind of jokingly roll our eyes when we talk about passing a work group or passing a task force. But I think it's an issue that sounds like based on even looking at some of the negative testimony or the opposition testimony, there may be a way to get together on this and figure something out. I mean, I'm certainly very open to having that conversation. I may have to duck out of here during the hearing because I have to present another bill. I just wanted to say that. Certainly willing to work with the sponsor and with you, Mr. Chair, Mr. Vice Chair, and anybody else.
Well, thank you, Senator Reedy. And I would just make this note, and I mentioned it, some of the folks are, I went to a conference, an NCOIL conference, where this subject was actually, there was a whole afternoon about what's happening around the country just in this space. And so it's not, this is a national conversation, not just a Maryland specific topic. And so.
Mr. Vice Chair, I do think it's important to say that it's not, I think there could be a stereotype that this might be something to get around the ACA, but that's why I wanted to make the point. I mean, these have been around for a long time. This is a long-standing type of way some people choose to obtain health coverage.
No, I understand that. Okay, any additional questions for Ms. Tracy? Okay, seeing none, we're going to go to Brenda Schweitzer, who's our next witness. Ms. Schweitzer, you have 2.5 minutes.
Thank you. Good afternoon. Thank you, Chair Kelly, members of the Senate Finance Committee. My name is Brenda Schweitzer, and I'm a member of Medi-Share and have been for over 10 years. I would like to thank Senator Eckert for sponsoring Senate State Bill 543, which would allow for my healthcare sharing ministry to maintain operations in the state of Maryland and exempt healthcare sharing from insurance code. Thank you for this gracious opportunity to come before you today and to share the story of my ongoing 10-year Medi-Share Christian Care Ministry journey. I am a resident and a homeowner here in Montgomery County. I have now over 30 years of professional experience working in the healthcare industry. This coming summer, it will be 20 years that I have been working full-time for my employer, who is a multicultural international pediatric practice. My story with Medi-Share, the families, began when the traditional insurance coverage that I had had for several years unexpectedly changed in January of 2011. I was notified by my insurance company that they were no longer offering individual coverage policies in Maryland, and I was being dropped as a client. This put me in a very unexpected position and giving me an opportunity to look around and see what else was out there, so to speak. I learned of our faith-based medical bill sharing community from a trusted family friend, Diane, who also was and still is today a Medi-Share employee. After talking with Diane a lot, much thoughtful consideration and prayer, I joined as a member in 2011 and have been an active member ever since. My experience as a member has been a very encouraging one in so many unexpected ways. One way has been by being enrolled in the Health Partners program a few years ago. The caring health coaches were there for me with the structured accountability I needed, kind, encouraging words, prayers, and I became healthier and graduated out of the program once my specific health goals were met. The annual verification check-ins for 3 years post-graduation are just as helpful for accountability. Reaching these health goals was not easy, and I have never felt alone in this, but only ever encouraged, edified along the way by my caring coaches. One of the things I have loved the most about being about Medi-Share has been given the opportunity to be an active volunteer member on the Medi-Share Member Steering Committee. This is a 20-member team of ladies and gentlemen representing the community at large from across the entire Medi-Share Christian Care Ministry. The Member Steering Committee serves as an important voice between our members and our board of directors, giving direct feedback and communication on various issues involving member voted on guidelines governing of our ministry. One important function of our steering committee has been participating in member appeal panels that are scheduled monthly or as on a needed basis. I have had the privilege of being a steering committee member for 8 years and now have the honor of chairing our steering committee as I fulfill the tenure of my last year on this team. Being a steering committee member has given me an opportunity that most members do not have.
Ms. Schweitzer, if you could maybe just bring it to some closure. We're under a sort of a tight.
Yes, sir. Yes, sir. Thank you. My apologies. One thing may be interested to know that in Maryland, since the 80s, healthcare sharing ministries have been dependably and faithfully serving fellow Marylanders for over 30 years. They have helped members share eligible medical bills. These communities are led by their faith, stay true to their biblical beliefs and healthcare choices.
Well, I think we may have lost Ms. Schweitzer. Okay, Ms. Schweitzer, I think
I'm sorry, there's interference and I'm not sure
Okay.
why. I apologize.
That's fine. Did you submit any written testimony?
Yes, I did, sir, and I
Okay.
apologize. It should be on the way to you, but I would just ask, please, please help support and say yes to the Senate Bill 543. It's important to me personally as a Maryland resident and so many other people. And thank you for Senator Eckert for her boldness and helping keep us supporting us. Thank you.
Okay.
I
Thank you.
do have resident testimony.
Okay, excellent. Any questions for Ms. Schweitzer? Okay, seeing none, we're going to go to the final witness of the day for, well, not of the day, but on Senate Bill 543, Arthur Warshaw. Mr. Warshaw, I see you there, and you've got 2.5 minutes, but you're going to have to unmute yourself. Okay.
Okay, I think I'm unmuted now.
Okay.
Thank you, Vice Chairman and members of the committee. My name is Arthur Warshaw. I live in Elkridge, Maryland, in Howard County. I've been a proud member of Samaritan Ministries for the last 25 years, pretty much since its inception. Participating in Samaritan Ministries healthcare sharing ministry has been invaluable for our family, both financially and emotionally. Almost 23 years ago, our daughter Grace Irene was born. Immediately after she was born, she stopped breathing and was taken to the NICU at Sinai Hospital. It was determined that she had a relatively rare genetic anomaly called trisomy 18. 4 days later, we brought her home and a 24/7 vigil started. We didn't know if she would survive from hour to hour because she regularly turned blue. The doctors told us all that we could do was feed her, change her, and wait. After 9 days, she died in my arms as I lay napping from exhaustion. The people at Samaritan decided to share our $10,000 NICU bill with the other members, even though her anomaly and the resulting medical bills was not something that was normally shared at that time. Within weeks, we started to get cards and letters from people around the country who we didn't know. Checking the mailbox for these cards and letters became the high point of our day as my wife and I and our 3 young children grieved the loss of Grace Irene. We read stories from other people who had endured similar losses, and not only did they offer emotional support, but enclosed with their stories and prayers were checks, which soon amounted to more than we owed the hospital. People that we didn't know sent money to help pay for our daughter's funeral and gravesite. Our burden was lifted and lightened by fellow Christians around the country. This would have never happened had we been part of a health insurance plan. I urge you not to take away this incredibly valuable ministry. It has helped our family amazingly, and I know there are thousands and thousands of other Christians around the country who participate, as was alluded to, some 7,000 just in Maryland alone. Thank you for your time.
Okay, thank you, Mr. Warshaw, for your testimony. Any questions for the witness, Arthur Warshaw? Okay, seeing none, thank you. That concludes the bill hearing on Senate Bill 543. We're going to now turn to an administration bill, Senate Bill 567. And I know we've got Jake Whitaker from the governor's office. Jake, and under our rules, since you're not senator sponsor, you're representing the administration, but you do get 5 minutes to present the bill on behalf of the governor.
Great, thank you, Mr. Vice Chair. Members of the committee, my name is Jake Whitaker. I'm with the governor's legislative office here to testify in support of Senate Bill 567. Since taking office, the governor and lieutenant governor have remained committed to addressing the heroin and opioid epidemic, including expanding access to services and reducing barriers to critical behavioral health services and substance use disorder treatment services as well. Senate Bill 567 expands access to these critical medical services by allowing healthcare practitioners to provide telehealth services via audio-only conversations like telephone calls. This bill will also require private carriers and the Maryland Medicaid program to reimburse for these audio-only services. Allowing audio-only modalities like telephone calls will make it easier for practitioners to serve patients in underserved communities who may not have the financial resources to purchase audiovisual technology. Additionally, this bill will be helpful for folks in rural communities who may not have access to broadband internet that makes audiovisual communications possible. This bill is an important next step in in making healthcare, specifically mental health and substance use disorder services, available to all Marylanders. And for the aforementioned reasons, we respectfully request a favorable report on Senate Bill 567. And if okay with you, Mr. Vice Chair, can I turn it over to Dr. Aaliyah Jones to testify?
Yes, that's fine.
Great, thank you.
Good afternoon. My name is Dr. Aaliyah Jones. I'm the Deputy Secretary of the Behavioral Health Administration, testifying in support of Senate Bill SB 567. With the COVID-19 pandemic and introduction of waivers allowing increased use of telehealth, especially telephonic services, this has led to an increase in the access of behavioral health services. Data from the Administrative Services Organization shows an increase in the number of people accessing mental health services using telehealth from 7,000 in 2019 to over 106,000 in 2020. And for substance use disorder treatment services, telehealth services were about 2,000 people in 2019, went up to 26,000 people in 2020. During this pandemic, it has certainly been important to keep consumers of behavioral health services engaged in treatment and accessible to those, and making sure the treatment is accessible to those who need treatment. In a recent survey conducted by the Behavioral Health Administration, about 70% of providers indicated that people were keeping more appointments or keeping about the same number of appointments as they were in the early spring. Telehealth has definitely proven to be an effective tool in keeping patients engaged in care, treatment, and services. When asked what successes have been experienced by individuals using telehealth, 73% said it eliminated the need to travel, 69% said it made treatment access easier, and 55% stated that patients were participating more. Our conclusion of all of this is that we have made a shift to telehealth in the public behavioral health system, and consumers are responding in a resoundingly positive way. Our licensing unit is currently seeing an increase in the number of providers stating that they will be providing services via telehealth, including outpatient mental health clinic and substance use disorder providers, all of which have and will continue to improve access to behavioral health services during the pandemic and after. This pandemic is an experience that the modern world has never experienced, so we don't really know what we can predict will happen in the future. However, we also can't ignore that we saw in 2020 another peak in opioid overdoses across the country, including in our state of Maryland. Research from previous disasters indicates that behavioral health impacts tend to remain elevated for up to 2 years or longer after a national disaster or after a disaster. There are many studies that have shown that anxiety and depression symptoms are up across the country, and the same would be true in Maryland as well. And the population that's been most greatly impacted by anxiety and depressive symptoms in our state are young people between the ages of 18 and 29 years old. Shockingly, at this moment, close to 60% of young people have symptoms of anxiety or depression. With regards to audio-only access, there have been numerous studies that have shown that there are sizable numbers of non-elderly adults who have Medicaid that reported that they've never used a computer or did not use the internet or email on a regular basis. If audio only ceases to be an option for payment for treatment services, there will be an increase in disparity of access and outcomes for those who don't have access or an ability to use these technologies, which affect the elderly, African Americans from urban areas, those who are self-pay, Medicaid recipients, and those who are on Medicare. Continuation of audio-only visits is essential to healthcare equity. In conclusion, only 43% of adults in the United States with mental illness received care in 2019. The COVID pandemic has put a direct impact on individuals with mental health problems and has put individuals with a history of behavioral health issues at a greater risk for relapse and misuse of substances. During this time, it is more important than ever to remove as many barriers to accessing needed services and supports as possible. For the aforementioned reasons, we respectfully request a favorable report from the committee on HB 567, and we will be happy to answer any questions.
Okay, thank you, Ms. Jones, for your testimony. Any questions for Ms. Jones from the Department of Health? Okay, I don't believe I see any. Thank you. We're going to go to the next witness, Mandar Jadhav from the Maryland Psychiatric Society. I've got, sir, you've got 2.5 minutes. I do see.
Thank you. I turned my timer on.
Okay.
My name is Mandar Jadhav. I'm a child and adolescent psychiatry fellow. I work in Baltimore, and I am here on behalf of the Maryland Psychiatric Society and Washington Psychiatric Society Joint Legislative Action Committee. So I wanted to thank you, Mr. Vice Chair, and all of the members of the committee for giving me your time. We have submitted written testimony in support of this bill. So I'm going to actually tell you about one Maryland family in particular that has benefited from the telehealth access. during this pandemic. So this family lives in the very southern tip of St. Mary's County. 2 young kids. Mom has a medical disability. Dad works 2 jobs to barely make ends meet. And both kids had very high anxiety and ADHD symptoms that made it difficult for this family to take the 2-hour ride to Baltimore to access care. And in their community, there are no child and adolescent psychiatrists that accept medical assistance. Their pediatrician did the best job possible to help this family, but it wasn't something that they could take care of. So this family was able to access our child psychiatry services in Baltimore, thanks to the telehealth access during the pandemic. And 4 months later, it has made a huge change in this family's life. This child is now able to attend school. The 2 siblings, 3-year-old and 6-year-old, are able to play together without essentially setting the house on fire. And mom is able to take care of her medical disabilities better. And dad is not feeling the pressure to have to work a 3rd job just to be able to get to a psychiatrist. Their challenge in St. Mary's County is anywhere they go, it's 2 hours away. And I think with this type of legislation would make a huge difference in keeping those families in care and continuing to provide care to all Maryland families in the future. Thank you.
Okay, thank you. Thank you very much. Any questions for the witness? You know, I would note that this, I guess, for everybody, and maybe I probably should ask this administration, you know, the bill's substantially similar to another bill we had heard, Senate Bill 3, and maybe somebody and the remaining witnesses can talk about what, if any, differences there are, but we'll take that next. So any questions again for the witness? Seeing none, we're going to move to our next witness, Adeyinka Ogunlegen, and from Comcast. I do see you there, and you've got 2.5 minutes.
Thank you, Senator. Good afternoon, Chair Kelly, members of the Finance Committee. For the record, my name is Adeyinka Ogunlegen. I am representing Comcast this afternoon. I am sure most of you are used to hearing from my colleague Sean Looney when Comcast testifies on legislation, but I am here this afternoon to testify in favor of SB 567 and the proposal to expand the access to telehealth services and coverage in the state of Maryland. While we all know that Comcast is a leader in telecommunications, media, and innovation, we are also a leader in bridging the digital divide and meeting the connectivity needs of those who would otherwise go without connections. For nearly 10 years, our Internet Essentials program has offered high-speed broadband access to students, veterans, seniors, individuals with disabilities, and other households that qualify for federal assistance programs, including Medicaid. However, as the pandemic has allowed all of us to realize there's still work to be done in bridging that digital divide. SB 567 would make sure that all households have all the means available to them to access critical healthcare services during this time. Through our ongoing partnerships with lawmakers, community-based organizations, and business leaders, we hope to continue expanding our network and providing high-speed broadband to the residents of Maryland. We do encourage a favorable report on SB 567 so that our healthcare partners and professionals can continue to leverage all of the means at their disposal to meet the healthcare needs of Marylanders and support remote patient monitoring services during the pandemic and beyond. Thank you again for the opportunity to speak in favor of this bill.
Okay, thank you very much for your testimony. Any questions of the witness? Okay, seeing none, we're going to go to the next witness. We've got Lori Doyle. Lori, you've got 2.5.
Thank you, Mr. Vice Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland in support of this bill with amendments on a couple of issues. The one you've probably heard some talk about, and that's the audio only issue. This bill requires commercial carriers to reimburse for audio only in the same way as in-person services, but it doesn't require the same of Medicaid. It requires coverage for audio only, but not reimbursement parity, if you will. Obviously, the two populations served by commercial carriers and Medicaid are very different. Medicaid population is poorer, so less access to broadband, smartphones, et cetera. And they're sicker, so they often need more and frequent support by peers and paraprofessionals. So we really prefer the language in Senator Augustine's bill, Senate Bill 393, which you've already heard. The second issue hasn't gotten as much attention, and that's remote patient monitoring and the need to really extend it in Maryland, particularly to behavioral health disorders. Right now, we're focused on the pandemic, and rightfully so. But community organizations have faced a severe workforce challenge prior to the pandemic. The pandemic has worsened it, but we expect we're going to have more of the same after we get out of the pandemic. And remote patient monitoring is really a game changer. It's a workforce extender. Right now, Maryland has a very narrow approach to RPM. It only covers 3 conditions: COPD, congestive heart failure, and diabetes, even though it's stated to be for at-risk chronic populations, which certainly describes behavioral health. Our members have been using some remarkable remote patient monitoring technology around medication adherence, and I've included that in my written testimony, so I won't go into it. So we really urge a favorable report on this, but with the addition of a language that will address these 2 issues. Thank you.
Okay, thank you, Ms. Doyle. Any questions for Lori Doyle? Okay, seeing none, we're going to go to the next witness, Ben Steffen. Mr. Steffen, are you here? Do not.
He's not in the meeting.
He's not in the meeting. Okay, and we're going to go to our final witness on this bill, Matt Celentano. Matt, I do see you. You've got 2.5 minutes, and you are the final witness on this bill.
Thank you, Mr. Chair. I will not take my entire 2.5 minutes. I'm Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland and AHIP, America's Health Insurance Plan, favorable with amendment on Senate Bill 567. We have been at the table to talk about updating our state's telehealth policy for months and months and months, through the summer, through the MHCC work groups, through various stakeholder meetings, including 2 subcommittee meetings over in the House in the past couple of weeks, to figure out what is the best and most appropriate way forward with telehealth policy. Just for context, though, I wanted to make sure that everybody on this committee understands that if the Maryland General Assembly takes 0 action on telehealth this year, it does not go away. Telehealth has been in Maryland and required for carriers to pay for it since 2012. It's permanent, and we will continue to utilize it, pandemic or not. But we will continue to sit at the table and figure out what is the best way to incorporate all the various pieces of telehealth legislation to move forward this year. And we ask for a favorable report with amendments. Thank you very much.
Okay, thank you, Matt. Any questions for Mr. Celentano? Okay, seeing none, that concludes the bill hearing on Senate Bill 567. We're going to now move to Senate Bill 570, another bill from the administration. And I see that we've got Jake Whitaker here again from the governor's office. Jake, again, you've got 5 minutes, or you could, also share the 5 minutes with somebody else from the administration. But Jake, you go first.
Great. Thank you, Mr. Vice Chair. For the record, Jake Whitaker with the governor's legislative office here to support Senate Bill 570. Senate Bill 570 is part of Governor Hogan's commitment to enhancing the safety and well-being of first responders, especially during Maryland's current pandemic response efforts. SB 570 will help protect the health and safety of frontline workers, including firefighters, police, and emergency medical services personnel, by requiring the medical facilities to notify them when they've possibly been exposed to COVID-19. The bill also permits medical facilities to contract with the CRIF system to facilitate this notification requirement quickly and efficiently. What this bill does is it's pretty basic. It basically just adds COVID-19 or SARS-CoV-2 to the list of diseases that are required to be reported to first responders when they've been exposed to it. So there's already things on this list like HIV, rabies, and tuberculosis, and we just think this is another step that we'll need to do even beyond the state of emergency. This codifies existing emergency orders that require first responders to be notified by medical facilities. We still think that a significant degree of risk will remain for first responders even after the state of emergency has ended. So we just want to make sure that this is in place to keep them protected. For the aforementioned reasons, we respectfully request a favorable report. I'd be happy to answer any questions, but if okay with you, Mr. Vice Chair, I'd like to turn it over to Dr. Delbridge to continue.
Okay, Dr. Delbridge, before we do that, any questions directly for Mr. Whitaker? Or why don't we wait until Dr. Delbridge testifies, and then we'll take questions for both of them. Doctor, you've got sufficient time within the 5 minutes or a little more.
Well, thank you for this opportunity again. I'm Dr. Ted Delbridge, the Executive Director for the Maryland Institute for Emergency Medical Services Systems. And by way of quick reminder, we exercise our responsibility to oversee and coordinate the EMS system in Maryland by licensing and certifying EMS clinicians or the EMTs and paramedics in the field, and by designating EMS operational programs or those agencies authorized to deliver emergency medical services in Maryland. Just a few of the things that we do. Section 18.213 of the health article which Senate Bill 570 seeks to amend, is incredibly important to frontline responders and healthcare workers. It ensures they're alerted when they may have been exposed to a communicable disease, thereby providing them an opportunity to assess their own personal risk and providing an opportunity to implement prophylactic measures as might be appropriate for the specific circumstances. In the case of the coronavirus responsible for COVID-19, it represents unique risks based on its mode of transmission, its potential for spread, and its prevalence in the community. Knowledge of potential exposure allows assessment of personal risk, as well as an occupational health approach to assessing risks within the workplace and among coworkers. And I cannot emphasize enough how important this has been over the past several months as fire departments and EMS agencies have done their level best to ensure they're adequately quarantining members of their staff appropriately while making sure they're also ready to answer the next call for help. We have undertaken some practical innovation that's been motivated by the pandemic and is made possible, quite frankly, by a statewide health information exchange and a statewide emergency medical services medical record. It's been facilitated by the Chesapeake Regional Information System for Our Patients, or CRISP, the state's health information exchange, and MEMS. And we link every positive COVID-19 case in a hospital with an available EMS record when there is one. And that enables notification of EMS agencies when there's a linked match. And so far to date, that has meant about 140,000 different notifications to EMS staff. The authorization that exists to use information in that way is by way of executive order. It will go away when the executive order expires. The need, however, as Mr. Whitaker has described, will not go away. And so for those reasons, we seek to codify the order and ensure that what is happening today continues to happen as the order expires. I'd like to thank you for your indulgence, and MEMS respectfully request a favorable report for Senate Bill 570. Thanks.
Okay, thank you, Doctor. So any questions for Dr. Delbridge or Mr. Whitaker? Okay, Senator Hershey.
Thank you very much, Mr. Chair. Dr. Delbridge, just a question. Is this language broad enough to, I guess, include all the different strains that we're hearing about related to COVID-19?
Yes, I think so. All the strains are subsets of the coronavirus and will all be relevant. And they all test positive the same way.
This 2019-NCOV. Then let me ask another question. Then is it too specific? I mean, everything else that we see as far as diseases seems to be very broad. I just don't know what 2019 NCOV actually means, and just wondering if does it capture enough for things that could possibly happen in the future?
Well, I definitely appreciate the question. And I would say that it definitely captures, it's broad enough to capture the coronavirus, which is currently responsible for COVID-19 and its variants. What it doesn't do, quite frankly, is capture the next virus that may cause the next pandemic 3 years from now. For sure, it doesn't do that. And the only way I personally would know to do that is to make reference to the possibility that we are able to designate whatever the communicable disease requirement is for some point in the future. That seemed a little far-reaching when we were deciding how to proceed at this very moment in time. But I'd certainly be open to that.
Okay. All right. Thank you very much. I appreciate it.
You're welcome.
Thank you, Mr. Chair.
Okay, any additional questions for either Mr. Whitaker or Dr. Delbridge? Okay, thank you. The only other witness signed up unfavorable is Vince McAvoy. And Mr. McAvoy, I kind of see half your face, and
I'm doing the best I can, Senator. I'm in the corner here. I do apologize. You can see some of me, yes, and hear me?
Sure. Yeah, we can hear you and we can see
Thanks.
half of you. So you're signed up unfavorable, and you get 2.5 minutes if you want to take advantage of it.
Thank you, Senator. I'm grateful for you. And thank you for the committee for listening. And Senator Hershey, thank you. You sort of took my steam. That's where I was going with this bill. As we look at the list there, and I have to reach over and look at my other computer where my notes are, that we have locked down an entire population rather than those just confirmed. And this is atypical to how we handle things in the state. And adding a new disease to this list of confirmed killers, HIV, tuberculosis, the plague, hemorrhagic fevers like Ebola, this is atypical. and that we have a bill, and we know that sometimes there's a little bit of sausage making in politics. We have a bill that includes literally every single law enforcement entity in the state. That there's concern with codifying this, and that's what I would ask the committee to resist. I think it would be simple to say the flu, and I think it's faithful to say that we have had 60 to 80,000 deaths every year in the U.S. from the flu for time immemorial. It's not good. We don't want these deaths. If we had been more stringent about cleaning our hands, right? Maybe we could have reduced some of this. But I am concerned that we are focusing on a brand name, and I'm very concerned that the medical officer is talking in terms of, and I'm very alarmed about this, the pandemic in the next 3 years. Committee, we don't get pandemics every 3 years. We don't. The last one before this was a decade ago. We've never had one where we've debilitated the entire state. And whether it's just for this bill or others that you're looking at, I just urge the committee to resist this ability to, this penchant to codify this, to build on this, and to keep coming back to this. Like this will never go away. Just like all flus goes away. That's why we no longer have the Spanish fever. I thank you so much for your time and listening, and especially for Senator Hershey for really putting the wind in that sail and taking that out of mind. It's fine. Thank you.
Okay, Mr. McAvoy, thank you for your testimony. Any questions for Mr. McAvoy? Okay, seeing none, that concludes the bill hearing on Senate Bill 567. We're going to now turn to Senator Pinsky on Senate Bill 522. And I see Senator Young, you've already popped in. Senator Pinsky only has himself and one other witness, but so hold on there, Senator Young. Senator Pinsky, again, you've got unlimited time, whatever you need to present Senate Bill 522.
Yeah, thank you, Mr. Vice Chairman and members of the committee. I won't take long. Many of you who've been around know about the issue of healthcare coverage. There are far too many gaps in coverage. People who don't have complete coverage or any coverage or under coverage in terms of the insurance. There's been talk nationally for many years, and I've been part of that conversation along with Senator Sanders on the national level of trying to come up with a system that ensured that everyone had quality, affordable health care, a more centralized system that made sense, that actually saved money, and with the savings of money covered more people with a high quality plan. This bill does not call for implementing such a system. What it does do, however, is pull together a committee of people, experts, to develop what I would call an implementation plan. If we had the authority and the right, and this may very well come true with this new administration, to implement a system just like we did with the all-payer system for hospitals, which we have had that for numerous years, and it's been very successful. This calls for a special task force work group to come up with what would a plan look like in the state of Maryland. Who would be covered? How would it be implemented? What would the cost be? You know, a lot of people say, oh, it's going to be too expensive. Well, let the experts try to cost it out. Clearly, the insurance companies will not be happy with this. I believe that the administrative cost and the profit margin and cost for lobbying and advertising is money that can be better spent on actually covering people in terms of healthcare. So, you know, clearly one system that reduces billing, simplifies billing. You don't want staff at a provider's office to be filling out 30 different forms. If you had one form and then at the end of the month, you explain what procedures, and then with the click of a button, there was one check transferred, it would be a lot easier, a lot more effective. Clearly, we need more preventive care. We have to ensure that acute care is taken care of. So this commission, you can read the bill yourself, calls on a number of people, Healthcare Cost Review Commission, people in the provider field, as well as other fields, to come together, come up with a plan, and then we'd have a plan on the books if we were given the option from the federal government then we can decide, is it the right direction to go in or not? So that's essentially what the bill does. For those who have been on the committee for a number of years, I've backed off the idea of trying to automatically put in place such a system. I do believe it makes sense. Canada's had it for 50 years. And while there might be reports that have been going backwards, the people would fight like hell if you tried to take away their single payer system in Canada. So that's the bill, and I'd be happy to answer any questions.
Okay. Thank you, Chair Pinsky. Any questions for Senator Pinsky on Senate Bill 522? Okay, thank you, Senator.
Mr. Vice Chairman, I'm going to head back to my committee.
Absolutely.
Thank you very much, committee.
Thank you. The only other witness signed up unfavorable is Roosevelt Mosley. Is Mr. Mosley in the House? Yes, I do see him. Mr. Mosley, you've got to, there you go. Mr. Mosley, you've got 2.5 minutes. You've got to unmute yourself, and you've got 2.5 minutes, and you've signed up unfavorable on Senate Bill 522.
So I apologize. I am actually was attempting to sign up for Senate Bill 552. So that may have been a.
Oh, okay. Well, that is in about 2 more bills. So we'll
sure
do in some advance. So you're not here on 522, just to confirm. Okay.
That's correct.
Okay. We'll come back to you in 2 bills from now. That concludes the bill hearing on Senate Bill 522. And now we're going to go to the first of 2 bills from Senator Young. Senator Young, Senate Bill 557, and you've got the floor, and you're the only witness, and you've got unlimited time. Senate Bill 557.
Okay, thank you, Mr. Vice Chairman, members of the committee. This bill is the Suicide Treatment Improvement Act. Rates of suicide completion have steadily risen in Maryland over the past several decades, and particularly during the pandemic, they've increased exponentially. A June 2020 survey discovered that 40% of adults are struggling with mental health or substance abuse, and about 2 Maryland residents a day are committing suicide. Suicide is the second leading cause of death for people between the ages of 15 and 24. It's 5 times more deadly than drunk driving. The bill as presented has been heavily amended from the version you're looking at. It eliminates the majority of the bill. There were concerns about the cost and the difficulty. So we've narrowed the bill down to basically 2 things. And I want to give special thanks to Shannon Alshar from the Frederick County Mental Health Association and Quentin Askew, President CEO of 211 Maryland, for helping craft a more realistic and more targeted bill. So the bill as amended basically does 2 things. One, that counseling and assessment for suicidal individuals or individuals who've attempted suicide may not have a co-payment, deductible, or co-insurance requirement applied when they seek counseling. And the second part is that the Maryland Police Training and Standards Commission shall implement standards that help ensure that when responding to an individual suspected of being suicidal, that the police officer will have access to an individual trained in counseling and assessment, because that's not how police officers are trained. And 2, responding officers do not use force when responding to an individual suspected of being suicidal. And then thirdly, that the individual suspected to be suicidal is approached in a calm and respectful manner. I think these amendments address the concerns that were expressed by the Maryland Department of Health, Psychiatric Society, the Hospital Association, and others. So again, the bill's narrowed down to these 2 things: no co-pays and the police establishing standards in how to approach potential suicidal people. And again, there are studies that show just reaching these people and talking drastically reduces those that go through with suicide. So with that, I would ask favorable consideration of the bill.
Okay, thank you, Senator Young. Any questions for Senator Young on Senate Bill 557? Okay, seeing none, that concludes the bill here on Senate Bill 557. We're going to now turn, Senator Young, to your second bill, Senate Bill 552.
Thank you. Thank you again, Mr. Chairman, members of the committee. I think you've seen this before several times, but again, continuing to allow credit history to be used in determining car insurance rates in Maryland is a socio-economical discrimination, and the proposed legislation would prohibit the use of credit history under Maryland law. Insurance underwriting decisions should be based on the risk of being insured, which is unsafe driving, not on someone's credit rating. And Maryland's Attorney General agrees that this shouldn't be used as a factor in establishing those insurance rates. A Federal Reserve Bank study presented to Congress 13 years ago now showed that the practice of using credit score to determine insurance rates disproportionately impacts minorities, young workers, and those in poor and minority census tract areas. This is supported by WalletHub's assessment that workers with income of $30,000 a year or less have an average credit score of 590, and that this again has a very negative impact on poor people. Frankly, they're already at the income levels usually that they're having trouble paying rent and eating, and we're pushing them down farther by charging them more for insurance because they can't keep their credit scores up. And again, people that have trouble with credit scores, though they go through the whole spectrum, are particularly heavy in minority communities like Prince George's County, Montgomery County, not Montgomery, Prince George's County, Baltimore County, and Baltimore City. We're really looking at trying to eliminate systematic racism. And I think to a great extent, this falls on minority groups. And again, it charges them more. I've made the point that insurance companies make you pay this up front. It's not like it's a payment plan and they're worried about getting paid. They're paid up front. So we're just penalizing people with low credit scores by using this as a factor to charge them more. A number of states across the country have already eliminated this, and over half of the rest of the states in the country are considering it. And I just, again, urge a favorable report. I was not able to get them here, but as a lifetime member of the NAACP, and I have spoken to them, they are very strongly in favor of this because, again, it affects them disproportionately. So we have some witnesses, but I would hope you'd consider this favorably this year. Thank you.
Okay, thank you, Senator. Before we go to your witnesses, any questions directly for Senator Young? Okay, seeing none. Senator, you've designated Franz Schneiderman as your lead witness. So as a result, Franz, you get 5 minutes.
And if you can excuse me, I'm going to have to get back to my committee too. So thank you very much.
Okay, thank you. Mr. Schneiderman, so again, you've got 5 minutes, and that 5 minutes starts right now.
Okay, thank you, Vice Chair Feldman, members of the committee, for the opportunity to address this bill. This is, something we've worked on for a while. I know. My name's Franz Schneiderman. I work for the group called Consumer Auto. We work on safety and fairness and transparency for Maryland drivers. We strongly support this bill because the current system of imposing really large financial penalties on people who need to buy car insurance if they have poor credit ratings or low credit scores, really, I do think is unduly burdensome, not only for lower income people, but also for people whose credit scores have suffered as a result of some kind of economic reversal or illness or giant medical bill. I think we all know that kind of thing can have a devastating impact on your credit score, but it's hard to see how it has any relationship to how dangerous you are on the road. Now, we also all know that a lot of factors go into a car insurance quote, but the credit score is a hugely important one. You see different estimates of how big the impact is, but Wallet Hub published some figures this in December that suggested there was an average of 41% discrepancy in Maryland insurance rates based on whether you had excellent or poor credit, with as much as a 95% difference for some companies. Now, a lot of price quotes have shown more than $1,000 in extra costs imposed on people with poor credit as a result of, to buy the auto insurance that the state more or less mandates we all have. That's, a really large burden on lower income people. And as I think we all know, having access to good personal transportation is important to economic mobility, economic opportunity, job and educational opportunities. So it's really a big economic burden on people who are already in difficult circumstances. It's the car insurance companies will claim that this is fair and appropriate because there's some relationship between the number of claims filed with people for the number of claims filed and your credit score, with people with poorer credit scores allegedly filing more claims. Even if that's true, and I haven't really seen the data, there's a difference between correlation and causality. And also, even if there is some modest correlation there, we're talking about giant penalties that can cost people $1,000 or more additional on their auto insurance rates. It's hard to see how that can be rationally related to whatever greater risk may be associated with a slightly lower credit score. Also, it's really up to the legislature to decide what constitutes fair and appropriate discrimination here, particularly for a product, again, that the state has more or less mandated that we all buy, or that we all have to buy to drive legally. I think that it's substantively unfair to use this factor and let it play as large a role as we now do. It's unfair, as I said, to lower income people. It's unfair because also imposes a large burden on people who have suffered medical or economic reversals, losing a job, suffering a terrible illness in your family. It's also unfair because I think it's well known that credit scores are notoriously inaccurate. Studies have shown that about 20% of people have significant errors in their credit reports that impact their risk tier. I think we've all had the experience, I know I have, of finding some odd charge in our credit score that we never contracted, and having to go through a somewhat difficult and time-consuming process of correcting it. Now, it's possible to correct that, but it puts a big burden on consumers, and not everyone knows how to do that. I also want to say that there's a tremendous public interest here in public safety on the roads, because about 36,000 people a year die on US roads and several million more are injured. The car insurance rate system we have ought to incentivize safe driving practices. But that's not the system we have. Our system, in our system, your credit score and where you live play a giant role in how much you pay. It would make much more sense from a public safety standpoint to have driving factors like your record on the road, the safety of your driving practices, to be foregrounded in setting those rates. And it is possible to move to a system that does that. 4 states, as have been mentioned in some of these hearings in the past, California, Michigan, Hawaii, and Massachusetts forbid the use of credit in setting car insurance rates. Massachusetts banned the use of it in 2011, and I don't think we've seen a giant spike in car insurance rates since then there. California passed a law in 1988 that forbids the use of car insurance and other non-driving.
Time has expired.
Okay.
Mr. Schneiderman, if you could wrap up, please.
Thank you. I just want to say lots of states are moving in the direction of focusing on driving record rather than credit score to set these rates. Maryland can do that too. It's fairer to consumers, better for public safety, and we'd like to see Maryland move in that direction. Thanks.
Okay. Thank you, Mr. Schneiderman. Any questions for Mr. Schneiderman? Okay, seeing none, we're going to go to our next witness, Christopher Dews. Christopher, I see you there. You got 2.5 minutes.
Yes, sir. Thank you so much, members of the committee, for the opportunity to speak to you. My name is Christopher Dews, and I'm a policy advocate for the Job Opportunities Task Force, where our mission is to help lower wage workers advance to higher wage jobs. We support Senate Bill 552 as a means of decriminalizing poverty and ensuring that auto insurance is affordable for lower income workers and job seekers. As you all may already know, mobility is key in Maryland's regional economy. The Census Bureau reported that more than 50% of Marylanders travel outside of their county for employment. This statistic is more pronounced for lower income communities of color, where there is a scarcity of jobs available by public transit. In fact, the Baltimore Sun recently reported that only 9% of jobs in the Baltimore region can be reached within 1 hour one way by public transit. Thus, for economic sustainability, access to a vehicle and affordable auto insurance is necessary. However, Maryland Auto reported last year that 500,000 Marylanders, roughly 12.8% of the state, drive uninsured, most citing the cost of auto insurance as the #1 reason for this infraction. This is mostly due to the use of non-driving factors, as France had already mentioned, and the use of credit history in the underwriting process, which incidentally raises rates on lower income communities of color. A 2013 study conducted by the Consumer Federation of America found that good drivers with low credit scores are charged as much as 123% more, double what drivers with high credit scores are charged, controlling for all factors, including the driving record. When examining quotes from Baltimore's 21215 zip code, the CFA found that one insurer charged individuals with poor credit 171% more annually than those with excellent credit. The poor credit person paying $2,788 a year, whereas the person with excellent credit paying $1,030 a year. Holding all factors constant, that is a difference of $1,758 annually. This is not uncommon, and when workers can't afford it, they just drive without it. As you also know, Maryland Transportation Code 17-107 states that driving without insurance is a crime punishable by up to 1 year of incarceration, a $1,000 fine, or both. As such, the 500,000 Marylanders who drive uninsured, many for reasons of affordability, risk incarceration every single time they try to go to work or take care of their families. This is what we call the criminalization of poverty, and it falls disproportionately on Black and brown workers. I just wanted to say very quickly, opposition is going to probably say that more claims happen for those who are of lower income. For those of lower credit. However, the problem with this is that that has nothing to do with a person's ability to drive. Right, that's more so to protect the insurance companies, which I understand, but that has nothing to do with a person's ability to drive or the risk while behind the wheel. Opposition testimony even said last week during the House hearing, when asked, is the use of credit history fair? They specifically said, one, that credit history has nothing to do with a person's ability to drive, and also
time has expired.
I'll say this one last point and I will be silent. Fairness is in the insurance business a rate that will allow you to predict reasonably well what your future losses are going to be. The premium you charge has to be enough to cover those future losses. Though that makes sense for the insurance companies, it does not at all benefit the actual consumer and ends up pushing them into a direction where they have to criminalize themselves just to be able to transport themselves. For those reasons, we urge a favorable report. Thank you.
Thank you, Mr. Dews. Any questions for Mr. Dews? Any questions? Okay, seeing none, we're going to go to the next witness, Michael DeLong. Michael, I do see you there. Unmute yourself. And you got 2.5 minutes.
Okay, thank you very much, members of the committee. My name is Michael DeLong. I'm a research and advocacy associate here on behalf of Consumer Federation of America. We're an association of over 250 consumer organizations. We were founded in 1968, advocate the consumer interest. We support SB 552 and a ban on the use of credit history in auto insurance. Americans think that the cost of auto insurance should be based on your driving record and your actions, which should mean whether you're a good driver and whether you have any tickets, accidents, or DUIs. But auto insurers use numerous socioeconomic factors to unfairly discriminate against consumers and charge them higher rates. Credit information is one of these. CFA strongly opposes the use of credit information in auto insurance. It's unfairly discriminatory, perpetuates systemic racism. To give just a couple of examples, in the zip code 2009 in Silver Spring, drivers pay an average annual premium of $962 for insurance coverage if they have excellent credit. But if they only have fair credit, that premium goes up to $1,295. And if they have poor credit, that premium goes up further to $1,672. That's a big increase for people who are already probably in disadvantaged circumstances. We see similar patterns across the entire state. In the zip code 21216 in Baltimore, the average annual premium for drivers with excellent credit is $1,760. Drivers with fair credit pay $2,399 per year. And if they have poor credit, they pay on average $3,114. Use of credit scores leads to much higher premiums for drivers. It can make auto insurance unaffordable. The criminalization of poverty, because in most areas, people need a car to get to and from work. And so auto insurance is a necessity. We also found that African Americans and Latinos are significantly more likely to have lower credit scores. So this actually, the use of credit information penalizes people of color. This is a racial justice issue. We also wanted to respond to a couple of arguments made by insurers. They say that low credit scores don't correlate to specific territories or classes of individuals, but Federal Reserve data show that low and moderate income communities tend to have, on average, lower credit scores than high income communities. And this ban will help consumers. It will decrease rates for people who are struggling, and it will actually help lift people out of poverty. And while consumers like to claim that their use of credit scores in history is colorblind, consumers know better. One African-American respondent in a recent survey, he said, "I felt that the odds were always against me. Banks will not give me loans." And since drivers are required to buy auto insurance coverage, the legislature has a special responsibility to ensure that this mandatory product is affordable. SB 552 will help accomplish that goal. It will ban the use of credit information in auto insurance. It will help reduce premium costs, will lower unfair discrimination in insurance markets, and it will promote racial.
Time has expired.
Thank you. Urge your support for this bill.
Okay, thank you, Mr. DeLong. Any questions for Mr. DeLong? Okay, seeing none, we're going to go to the final witness signed up favorable, Martin Schwartz. Mr. Schwartz, you've got 2.5 minutes.
Thank you, Vice Chair. I appreciate the opportunity. Members of the committee, I'm the president and founder of Vehicles for Change. Vehicles for Change believes that the net result of systemic racism and social injustice is poverty. And one way that as a society we lock families in generational poverty is by limiting access to transportation. The #1 barrier to employment for families living in poverty is transportation. It's been studied for years. It has been the same since we started this program. One of those limits is the high cost of car ownership. And one of the key drivers of that cost is car insurance. Vehicles for Change is a 21-year-old nonprofit organization that has provided more than 4,000 cars to low-income families in the state of Maryland. Almost all of those individuals have had poor credit scores and pay more for their car insurance than the minimal fee that they pay for their car, which is $900. It's not unusual for a low-income family to have to make tough financial decisions. And that can often mean the difference between paying their car insurance or feeding their children. I think for all of us here, that would be a pretty easy decision to have to make. Recently, we've heard a lot of conversation around supporting social equity, often from our lawmakers, and actually in a review of the insurance websites, they all seem to state that they also support social equity in our country. So this is a chance to let those insurance companies back up those bold statements and stop using this social inequity practice of credit scores to determine the cost of car insurance. By doing so, more Marylanders will be able to afford a car and thus be able to gain access to higher paying jobs, provide greater opportunities for their children, and potentially we can slam the door on generational poverty. Vehicles for Change is in full support of this bill, and we hope that you'll find a favorable result. Thank you.
Okay, thank you, Mr. Schwartz. Any questions for Mr. Schwartz? Okay, seeing none, we're going to go to the unfavorables. We're going to start with Roosevelt Mosley. Mr. Mosley, I know you had inadvertently signed up on a prior bill, but with as a prerogative of the chair here, that clerical mistake, we're not going to penalize you for. So we're going to start with you and then we'll go to the other unfavorables. Okay. So Mr. Mosley, you've got 2.5 minutes.
My apologies, and thank you, Vice Chair Feldman and members of the committee. I appreciate the opportunity to speak to you on today. My name is Roosevelt Mosley, and I'm a principal and consulting actuary with Pinnacle Actuarial Resources, and I am providing testimony today on behalf of American Property Casualty Insurance Association, APCIA, in opposition to Senate Bill 552. Automobile insurance companies use many different rating factors, including credit-based insurance scores, to determine the relative cost of insurance for policies with different expected losses. As is the case in most states, insurance companies in Maryland must file their rating plans with the Maryland Insurance Administration and thus must justify the use of rating factors in those filings. The primary way that companies justify the use of their rating factors is based on their own experience. Insurance companies provide information related to loss ratios, claim frequency, claim severity, and/or pure premiums to show that the policies with different risk characteristics produce loss experience that justifies different treatment in the rating plan. The analysis of these factors generally occurs in a multivariate manner, which is important because this analysis demonstrates the use of credit is not duplicative of any other rating factors used by insurers. If insurance companies are prohibited from using credit-based insurance scores, there is no combination of factors that is currently used by companies that would allow them to replicate the risk segmentation value produced by credit-based insurance scores. The result is that rates would be less reflective of true costs. And ultimately, the rates that have been filed by insurance companies have been demonstrated to be supported based on both their own experience as well as experience of studies that are available in the public. Given the removal of significant risk-based rating factors, one of the results would be a significant rate disruption. Policyholders currently paying lower rates due to credit-based insurance scores would see a rate increase, and these increases would be subsidized by those who would pay lower rates but produce higher losses. And while the common assumption is that all policyholders with higher credit-based insurance scores are wealthy and can afford higher rates, the reality is more nuanced. In reality, there are policyholders with higher income and lower credit-based insurance scores, as well as policyholders with lower income and higher credit-based insurance scores, which has been demonstrated by independent studies, including the FTC study. In the end, we all want insurance system to be fair as well as sustainable. Efforts have been initiated by NCOIL and the NAIC to study the issue of bias in rating and to develop solutions to address it. As it has become clear from discussions within these groups, defining unintentional bias is a significant challenge, and then determining how to correct for the issue in rating will be another significant challenging step. Ultimately, we believe a collaboration between insurance companies, legislators, regulators, and consumer representatives can result in a comprehensive solution that allows for an insurance system that maintains cost-based premiums and racial equity, rather than attempting to use individuals on specific variables. For this reason, we ask the committee members vote no on this bill. Thank you, and I remain available to answer any questions.
Okay, thank you, Mr. Mosley. Any questions for Mr. Mosley? Okay, seeing none, we're going to go to the next witness, Robert Etten. Mr. Etten. Mr. Etten, you got 2.5 minutes, and you got to unmute yourself.
Thank you very much, Mr. Chairman. Robert Etten on behalf of the American Property Casualty Insurers Association. Our members write roughly 60% of the automobile insurance in the state of Maryland. And we are opposed to this bill. I was at the table back in 2002, 19 years ago, when this bill passed. And the law that you have before you that this bill amends was a compromise. Back then, there were only 3 states in the country that banned the use of credit: Hawaii, California, and Massachusetts. Today, there are only 3 states in the country, 19 years later, that completely ban the use of credit, and it's the same 3 states. What we did in the state of Maryland was reach a compromise and a middle ground. So you got 3 states that ban it, you've got 1 state that has a middle ground, and you've got 46 states that do not limit the use of credit. That compromise said that you could only use credit for purposes of underwriting on the initial policy. It's absolutely prohibited that it be used on any type of renewal. And on the actual policy, there's a limit. It can only adjust the premium up to 40% down or 40% up, and that's it. You have to you have to review the credit scores and the other factors every 2 years. You have to decrease the premium that you're charging based on an increase in the credit score. You have no choice about that. We have probably, I don't know, maybe a dozen different things that are in that compromise. You can't require a particular payment plan based on credit. You can't refuse to underwrite, cancel, or refuse to renew based on credit, etc. The one thing I would really like to emphasize is that over the last 19 years, we've had 4 different governors, 2 from each side of the aisle. And we've had probably at least 5, maybe 6 different commissioners, insurance commissioners, appointed by those governors. And not one of those insurance commissioners has ever found that the use of credit violates Maryland law, which is crystal clear. And it says you can't cancel or refuse to underwrite or renew a particular insurance class based wholly or partly on race, color, creed, sex, or blindness of an applicant or policyholder, or for any arbitrary, capricious, or unfairly discriminatory reason.
Okay.
I think he got stuck in the matrix.
Yeah, Bob, I think you're okay. Wrap up, and your connectivity.
I will.
Good.
Every study,
Okay, Bob, I think we're, getting a little connectivity problem here with you.
50%, if you ban the use of credit, roughly 50% of current policyholders would pay more, 32% probably wouldn't be impacted, and 18% might get a reduction. Thank you, Mr. Chairman.
Okay, we lost you for about
Thank you.
seconds, but I think we got the gist of your testimony, Mr. Etton.
I'm done.
And we've got Senator Benson is itching to ask you a question, Mr. Etton. So Senator Benson, if you could unmute yourself and. Senator,
Okay.
why don't you've got the floor, Senator Benson, if you have a question.
Thank you very much.
Yes.
I'm listening very carefully to the testimonies that have been given here. I would, let me make a statement and then ask a question. It's a bread and butter issue. It reminds me of redlining. And of course, I'm inside the Beltway, so I could tell you numerous stories about how the credit score has been considered when we talk about the people in my district who need transportation to get back and forth to work and to do other things. Would you not agree that the testimony that's been given hinders our college students? A lot of times they have this huge debt that they have to pay off, and then the credit score is used to determine how much the insurance is going to be on their cars. I mean, I could go down the list of things that I have found, the issues that I have found, the problems I have found when it comes to insurance, auto insurance, particularly inside the Beltway of Prince George's County. How do you address that? I mean, I'm listening very carefully to what has been said this afternoon, and it kind of gives me a heartburn because it really does, in fact, remind me of redlining. This is a form using a credit score to determine the insurance on a car, particularly for our college students, for people of color, is troubling. And I'll tell you, I don't care what's on the books, it's a fact. So how do we address that? How do we fix it?
Okay, Mr. Etton, I think that's directed to you. If you can hear us. Are you connected?
Mr. Enton or Mr. Mosley can answer that question, please.
Okay.
Because it's a form of redlining. I'm telling you that right up front. It is a problem. It is a problem.
Okay, since Mr. Etten, you appear to be frozen on the screen, we'll let Mr. Mosley, why don't you take a crack at it, and then we're going to go to any other questions. So in the absence of Mr. Etten being connected, we're going to go to Mr. Mosley if you want to respond to Senator Benson.
Sure. And thank you so much for your question, Senator Benson. So the issue, the issue of redlining and grows out of a racial bias era that we all understand was unfair, that we all understand should never have happened and was not right. And so I 100% fully agree, and most in the insurance industry would that redlining was wrong. The use of credit-based insurance scores in the industry is not to keep any particular group from purchasing insurance, from being able to access insurance. There are essentially studies that have been completed that show that based on insurance score, they are predictive of insurance company claims. And much like any other factors that they use, most insurance companies ensure that the information that is used or that is developed by the use of credit-based insurance scores does not overlap with any other characteristics. As an example, the age of the driver is one of the characteristics that is used pretty significantly in rating insurance, and is generally going to be a variable that probably carries more weight than credit-based insurance score. And understanding the relationship of younger drivers to potentially their income levels, the reality still remains that younger drivers are less experienced and cause more accidents and thus cost more to insure. And so the idea behind the use of credit-based insurance scores is not to single out any group. It's not to single out any income class. It really is about insurance companies being better about matching the costs that they're taking on to the premiums that they charge. And so it really comes down to a system of equity and fairness in terms of the cost of insurance versus the cost you bring to the system. As you have stated, and as I indicated earlier, we as the industry are committed to working through this particular issue, especially as it relates to what is being done with NAIC and NCOIL to address this issue comprehensively, not on a factor by factor basis. And that is, again, what we as the industry are still remain committed to. But we certainly do not condone what happened in redlining or any form of it that would continue to happen today.
Okay. Any additional questions? I think Mr. Etten may be back on. Or any additional questions for Mr. Etten before we move to the next witness? Okay. Seeing none, the next witness is Bryson Popham. Mr. Popham, you're muted currently. You're going to have to unmute yourself. Okay, you got 2.5 minutes.
Chairman, members of the committee, Bryson Popham appearing before you today in opposition to Senate Bill 552 on behalf of 4 different clients: the Insurance Agents and Brokers, the Maryland Association of Mutual Insurance Companies, and 2 individual insurers, Agency Insurance Company and Progressive Insurance. As is often the case, my prepared testimony shifts when I listen to the testimony and particularly the questions that are asked. So I will simply say this is not a new issue to the Senate Finance Committee. You've heard it many times before. I've appeared before you before, as have my clients, in opposition to this type of legislation. If you pass it, 2 things are guaranteed to happen. Rates will go up because the math hasn't changed with respect to credit. If you eliminate credit as a permissible rating factor, 2/3 of people will see their costs go up, 1/3 of people will see their costs go down. So that is one thing. And the other point I'd make is with respect to the gentleman's comment earlier about the number of uninsured people on Maryland roads. That's a chronic problem, I agree. This will do nothing to help that problem. In fact, it will exacerbate that problem. There is one thing that I know of that will help automobile insurance rates go down. And it is expensive, I acknowledge that, but that is competition. And on behalf of all of my clients today, that's what I am urging the committee to keep in mind. You want to have companies large and small. I'm representing both types today. You want all companies to compete for the business of your constituents. That's the only way that you can help drive down the cost of automobile insurance. Now, with respect to Senator Benson's very good question, that's respectfully a different issue. It is a fairness issue. It is not an insurance rating issue. We have a statute on the books. It's been there forever. It says that rates cannot be unfairly discriminatory. You have a regulator who has to enforce that statute. It's the insurance commissioner. Every insurance commissioner I know of has done a good job doing that. And if there are other measures, Senator Benson, that you wish to discuss, I'm happy to discuss them with you. But changing the way automobile insurance is rated, I don't think is the right way to go about this. Now, I have a document that I'm going to show to the committee, and it is on its way to you this afternoon. I got it 10 minutes before the hearing. It is from one of my clients I'm representing today. I testified on a similar document last week in the House Economic Matters Committee. It addresses head-on the question about correlation. Every insurance commissioner has testified that there is a correlation between credit-based insurance scores and propensity for future loss, which is, of course, what insurance companies are seeking to ascertain. This chart that you will receive shows a high correlation between a type of driving behavior, hard braking, which leads to more accidents and
time has expired,
and credit-based insurance scores. So I would encourage each member of the committee to take a look at that document, and we'll be happy to discuss this issue further with any of you individually. Thank you, Mr. Chairman.
Okay, thank you, Mr. Popham. Any questions for Mr. Popham? Okay, seeing none, we'll go to the final witness on this bill, Andrew Kirkner. Mr. Kirkner, you have 2.5 minutes starting now.
Thank you, Vice Chair Feldman, members of the committee. My name is Andrew Kirkner, and I'm here today on behalf of the National Association of Mutual Insurance Companies. We are a national trade association representing mutual insurance companies. We have more than 1,400 members nationally, and in Maryland, we have 11 members that are domiciled in the state. I thought, as Mr. Popham mentioned, our testimony shifts as we hear those talk before us and hear some of the questions. So I thought maybe instead of the prepared remarks that I have, and we did submit written testimony on this bill, I would draw your attention to that in your packet. But I thought instead of doing that, I may just pause for a second and step back to explain a little bit how insurance is priced and why this issue is really important to our companies. Insurance, if you think about it, is unique in the marketplace. It's one of the few products where the producer of the item, in this case, insurance coverage, is required to price it before we know what it cost. So in any different industry, the widget manufacturer, for example, they know how much their component parts cost. They can price their product accordingly. So an insurance company's job is essentially to figure out what its insurance is going to cost, right? And how to price its insurance before it knows what it costs. The way they do that is to use a wide range of factors to predict risk. And that's really where this fairness discussion focuses. And the question really is it more fair, and in our view, it's more fair to accurately price risk and to charge a commensurate premium. And so the removal of credit as one of the permissible rating factors would turn that on its head. We know this because we know that a credit-based insurance score is predictive of risk. The FTC study from 2007 shows us that. Georgetown study in 2016 shows us that. Again, both of these are linked in my testimony, my written testimony. We also know that credit-based insurance score is not a proxy for race or income. The FTC study again shows us that in 2007, and the Georgetown study in 2016 does a very comprehensive overview of credit-based insurance score not being a proxy for income. And then finally, Mr. Vice Chair, I'll wrap it up by saying there's the Arkansas Department of Insurance did a multi-year study in which it reviewed how many folks were benefited and how many folks were harmed by the use of credit as a rating factor. Nearly 80% of folks either received a benefit, a decrease in premium, or no impact to their premium at all. 19.8% of folks received an increase. So as you can see, Mr. Chairman, there would be, Mr. Vice Chair, there'd be a disproportionate impact should credit be removed. Finally, I appreciate the opportunity to appear before the committee today. Be happy to answer any questions.
Okay, thank you, Mr. Kirkner. Any questions for Mr. Kirkner? Okay, seeing none, that concludes the bill hearing on Senate Bill 552, which takes us to the final bill of the day. And for that, I'm going to turn it over to Senator Augustine to preside.
Thank you, Vice Chair Feldman. We will next hear Senate Bill 513 from Vice Chair Feldman. It's all.
Thank you, Senator. So let me start by saying that most of us absolutely have been impacted either directly or indirectly by cancer. And I know of at least one member of this committee who's a cancer survivor, and she talks about that quite often in the committee. So this is a very narrow bill and deals specifically with oral oncology drugs for cancer patients. And I'll say at the outset that the subcommittee in HGO that has jurisdiction of this issue is working on the bill, so there could certainly be some amendments forthcoming soon. But no matter what HGO and the subcommittee does, my intent with this bill is to make sure, very specifically, is to make sure that cancer patients get their oncology drugs, their oral oncology drugs, in a timely fashion and in a manner that maximizes the likelihood that those drugs will be effective. That is the intent of this bill. And so just a little background. So oral oncology medications under our current law are considered specialty drugs under Maryland law. And if you look at the fiscal note, it specifies, so we're in the draft bill, you'll see there's a pretty tight definition of what constitutes a specialty drug. So what that means is that currently in Maryland, it requires the cancer patients to obtain their oral oncology drugs. They have to get it from a pharmacy benefit manager or a specialty drugstore, sometimes owned or operated by the PBM. And that's how it operates currently in our state. And so, it has been brought to my attention, and again, I think maybe we'll have some testimony to this effect, that some cancer patients actually endure delays in receiving their oral oncology drugs, sometimes for weeks or longer. And this is not one of those bills that it's about economic interest. We're talking about life and death here, right? You can't have a delay in your oral oncology drugs if you're a cancer patient. That is highly problematic. So what Senate Bill 513 is designed, again, intended to be an effort to help cancer patients streamline that treatment and provide them with some more choices and increased access to their life-saving treatment. So specifically what Senate Bill 513 does, it doesn't change the definition of specialty drug, but it would expand on current law by authorizing a physician who holds a valid dispensing permit. Again, it has to hold a valid dispensing permit and complies with all of Maryland's in-office dispensing laws. And you can read a little bit about that in the fiscal note. The fiscal note writer did a good job. It allows that physician to mail or deliver oral oncology specialty drugs directly to the patient rather than having to go through a PBM or a specialty drugstore. That's what the bill is intended to do. Now, existing Maryland law, this is, I think, important. So under our current law, we already, under current law, allow patients with diabetes, HIV, and AIDS to get their drugs directly from their physician. That's current Maryland law. All Senate Bill 513 does, it adds oral oncology cancer drugs to that list. Also, I think very significantly, under federal law prohibits PBMs from requiring Medicare patients to get their oral oncology drugs from a PBM-owned specialty pharmacy So physicians currently in Maryland are allowed to dispense oral oncology drugs to their Medicare patients. And basically what Senate Bill 513 would do would be expanding access by applying the same standard to cancer patients who happen to be in Maryland, who happen to be under 65. So if you think about it, and again, we'll have some testimony on this. If you think about it, it makes sense. The oncologist is the doctor who can answer questions directly with the patient that they've been treating. They've got all the medical records. They happen to have a relationship, a doctor-patient relationship, more nimble opportunity if dosage needs to be adjusted quickly, and the like. And you don't have to depend on a middleman, a specialty pharmacist or drugstore to play middleman before the drug can get to the cancer patient. And so to me, it makes sense. Now, as far as opposition, I mean, not surprisingly, we have the PBMs, because this is an economic self-interest issue, submitting opposition testimony. What I have to say I found a little bit surprising or interesting is the Department of Health written testimony. If you look at it, and this captured my, I have to say, I'm going to just read it. In the second paragraph, they say, our opposition to this bill, I'm going to quote it, is primarily based on the fact that the treatment and diagnosis of cancer is outside of the physician's scope of authority. That is what they say is the primary reason they're opposed to the bill. They don't believe, I guess, that the diagnosis of cancer and the treatment is within the scope of an oncologist's scope of authority. Now, with respect to our Maryland Department of Health, I'm not sure I quite understand that being the basis. But that said, as I say, in some bill would put Maryland law on par with federal law governing Medicare patients already in Maryland. And it puts oral oncology drugs also on par with diabetes, HIV, and AIDS by allowing a physician with a valid permit in compliance with Maryland in office dispensing law to dispense by mail directly or other method, again, the oral oncology drugs, again, directly to the patient. That's what the intent of the bill is. And with that, members of the committee, I will field any questions. I know we've got some witnesses behind me, and let me just look at the witness list. Well, Senator Augustine, you've got the witness.
Absolutely, I do.
So that's really the intent of the bill. And again, I hope to work with HGO through some of the issues that have been raised by the opponents, and hopefully we can get this through past the finish line. But that's what I got, and that's what Senate Bill 513 does.
Thank you, Vice Chair Feldman. Are there any questions for the bill sponsor? Okay, seeing none, we'll move to the 5-minute testimony from Dr. Kashif Ferozi. You have 5 minutes.
Thank you so much, ladies and gentlemen of the subcommittee and Chairman Feldman, for your support and your introduction. My name is Kashif Ferozi. I'm a medical oncologist at Maryland Oncology Hematology, also the director of the White Oak Cancer Center in Silver Spring, Maryland. And I've been taking care of cancer patients now for about 20 years. Cancer care has gotten quite complicated over the course of the past 20 years and requires a lot of care coordination, especially related to quick, nimble changes that have to happen in the management of patients whose labs may change, their kidney function may change, their liver function test may change, or they may end up getting admitted to the hospital with a new brain metastases, all of which can require quick changes in the medications that patients are receiving. This bill, SB 513, aims to improve the patient care by removing obstacles, improving care coordination, and most importantly, respecting patient choice and preference when it comes to how they receive their care. Today, in our office, we have a medically integrated dispensing pharmacy where we are constantly working with our team of 3 pharmacists and around 9 or 10 pharmacy techs to ensure that the patients receive their drugs in an appropriate time, in a very timely fashion, but also to do so in a way whereby all of the medical issues related to that patient's management are communicated between the physician and the pharmacist to ensure that there are no complications. The pharmacist and the physician work together, reviewing the medical records, the labs, and anything that happens to ensure that medications are given appropriately. In addition, before a prescription can be delivered to the patient or given to the patient, the physician has to sign off on it, which provides an extra layer of assurance. In the current model that we have today, we don't have that level of communication. There is really no communication between the physician and the specialty pharmacy and the specialty pharmacy's team. And as a result of that, we see lots of issues. Number one, there is really little to no coordination of care between the physician and the specialty pharmacist. If a patient with cancer gets admitted to the hospital and gets discharged, their medications may be entirely changed. And there could be changes in their liver function or kidney function, all of which require changes in their doses or in the entire medication. That minute-by-minute information is not available to specialty pharmacies. And as a result, not only is their utilization review not able to provide accurate information, it can actually provide dangerous recommendations. So that care coordination is really important. Number two, we see a reduction in waste. When you know what's happening to the patient in real time, and you know what doses need to be changed or whether or not a recommendation of a regimen needs to be changed, you can deal with that appropriately. I have on a regular basis, I have patients who come to me and I say, I'm sorry, we have to change your medication because your disease has progressed. And they say, that's fine. After they're shocked, they deal with that. Then they say, what do I do with this bottle of drugs that just got delivered to my house today? And it's $10,000 for a month's prescription. This happens not on an occasional basis. This happens all the time. And the reason it happens all the time is because you cannot create a system that has more bureaucracy and more layers and expect that to result in more efficiency. The third thing is delays. Very often, drugs are given in combination with intravenous therapies. We have an entire team in place to ensure that we can get the authorizations, the patient support, and schedule the patients for their intravenous chemotherapy. Unfortunately, the oral drugs oftentimes cannot be coordinated accordingly because if they go to a specialty pharmacy, there is a delay. Studies have demonstrated that the time that it takes for an integrated oral dispensing pharmacy to turn around the drug delivery compared to a specialty pharmacy can be anywhere between 5 to 7 times shorter. This is very commonly known within the medical community. And so our hope is that we can make this better. We are currently prescribing these drugs to our patients with Medicare, as Chairman Feldman said. What we are asking, especially in the middle of a pandemic where patients are trying to stay home, that we have the ability to not only continue to care for those patients, but also to be able to have those drugs delivered to them when they are not able to come and pick up those drugs. That is really, in essence, what we're trying to do. We're trying to remove obstacles. Patients want this, physicians want this, pharmacists want this. There's really nobody who would not want this. And so from our perspective, this is really about patient choice, patient convenience, and ultimately improving the lives of patients with cancer. Thank you, and I'd be happy to answer any questions.
Thank you, Dr. Feroce. Members of the committee, are there any questions for this witness? Okay, seeing none, thank you so much for your testimony. We'll move on to Caroline Boutros. You have 2.5 minutes.
Thank you so much, everyone, for allowing me the opportunity to speak today. I'm one of 3 licensed pharmacists at Maryland Oncology Hematology, managing the oral oncolytic therapy for our patients. My role in our medically integrated dispensary is to review these oral therapies with our patients, discuss their clinical impact, review drug interactions and side effects, and answer any pertinent questions they may have. We currently dispense prescriptions under various insurance prescription plans, both commercial and Medicare Part D, as previously mentioned. Upon receiving prescription orders from the oncologists, my team and I review the medication for therapeutic appropriateness, examine drug interactions against current medications listed in the patient's charts, analyze recent and future labs, and review the side effect profile with the patient. This compilation of steps is called a DUR, a drug utilization review. This review is a structured, ongoing determination of medication therapy prior to dispensing and is routinely discussed between myself, the physicians, and the patient. Once any underlying drug-drug interactions or drug-disease interactions are debated, a prescription will then move forward in the process. Whether my team continues to process that prescription or we have to send it out to an insurance dictated specialty pharmacy, we continue to remain available to the patient for side effect management and questions. I would like to highlight that often a patient will turn to us first when having an unwanted side effect because they are more comfortable speaking to a familiar voice and because we have direct access to their chart, as Dr. Ferozvi said, and to the physicians themselves. We can see their lab work, their liver function tests, their renal clearance, their updated weight, height, and BMI, and we can see whether or not they have been hospitalized recently. More importantly, we can see how all these values affect their medication and dosing. Our medically integrated dispensary is in a unique position to bridge the gap between patient, physician, insurance, and pharmacy, eliminating the potential for delays and providing quality care to our already suffering patients. This gap that lies in communication between specialty pharmacy and patients can cause severe delays in therapy, where scripts will sit in a prescription queue for days, weeks, and sometimes even up until a month. We would like to eliminate these delays in therapy and remove any obstacles causing worry and confusion to our patients in their already fragile state. These are our patients, not prescription numbers in a queue. Thank you very much.
Thank you, Boutros. Colleagues, we have any questions for this witness? Okay, thank you again for that testimony. Hearing no questions, we'll move on to our good friend, Senator John Pica.
Thank you, Senator. Vice Chairman, members of the committee, and the esteemed senator from District 9. There's little I can add. So what I like to focus on is what you're going to hear from the crowd behind me. And so you're going to hear that we're not subject to drug utilization review, and that is wrong. My client, Maryland Oncology Hematology, and the U.S. Oncology Network, they employ pharmacists on their staff. This bill would allow greater access for cancer patients and convenience for cancer patients for oral oncology drugs. So oral oncology drugs are the equivalent of chemotherapy. So imagine having to wait several days, if not weeks, and it's sometimes up to 30 days to get your chemotherapy. That's what's happening with oral oncology drugs. Many times we find bills that try to bring our laws up to current standards, medical standards. And because of the advances in medical care, a lot of our statutes, including the dispensing statutes, has lagged behind advances in care. This bill would allow physicians to dispense oral oncology drugs. And as the vice chairman stated, we do that now, or the physicians at Maryland Oncology do that now. They do that for all Medicare patients. And contrary to what I've heard from some of the opposition, and you just heard from Ms. Boutros, the pharmacist at that practice, we do this in commercial plans. And this will not force any carrier to require a physician to dispense an oral oncology drug if that carrier is not in their pharmacy network. So the physicians at Maryland Oncology Hematology do dispense these drugs to patients who are whose plans are participated in by the oncologists. So the difference with this bill and current law is it would allow the physician to mail an oral oncology drug to a patient. And that would avoid any delays that exist today, because after they're prescribed, the physician has to tell the patient, I'm sorry, I can't give you this drug. You have to wait for a phone call from a PBM. And sometimes that takes days. Sometimes it takes a week. Sometimes they can't find the patient. It might be an 800 number that the patient doesn't want to respond to. These patients have to wait. You just heard a bill about credit and how it discriminates against the poor. You'd be surprised to learn that if a patient does not have money to pay for their copay, which could be as much as $3,000, guess what the PBM says? We're not going to give you your drugs. Go back to your physician and see if your physician can get a grant for you. And that's what happens. The
Thank you,
patient has
Senator.
to come back to the physician, and the physician has to, and his or her staff has to look for grants before PBM will issue or grant a cancer patient the equivalent
Time
of
has expired.
chemotherapy. Thank you. I believe this is a good bill, and we're happy to answer any questions that the committee has.
Thank you, Senator. Appreciate that. Any questions for this witness? Okay, the last witness who is favorable as was presented, Benjamin Lowentritt.
Thank you. Thank you, Mr. Chair, Senators. You know, I am a urologist with Chesapeake Urology and primarily take care of men with prostate cancer. And like the hematology oncology practice, Maryland Hematology Oncology, we have an integrated dispensing program within our office setting at Chesapeake Urology. And, you know, I'm not going to reiterate most of what is said, but I do want to drive home one set of points, which is our dispensaries are certified. They are subject to audits by the PBMs that certify us and that enter into contracts with us, by the state, by Medicare, essentially. We meet all of the quality metrics that are needed for anyone that is going to dispense these drugs. What we're talking about today is that when we enter into these arrangements with the payers, the PBMs in this case, they put anti-competitive language to restrict our ability to service our patients, plain and simply. There's language that prevents us from being able to get these patients that live in what really we have to say they're almost in a constant level of crisis. We talk about how COVID has created a new crisis, and it has. It's certainly made people afraid to leave their home, especially cancer patients. But these cancer patients often are afraid of that all the time. And so for us to be able to adequately service them, we want to be able to provide the full level of service, which might include mailing them their medication. These drugs are all mailed. When a specialty pharmacy sends the drug to the patient, they mail them their drug. So what the pharmacy benefit managers, through what are often the pharmacy benefit manager owned specialty pharmacies, when they send their patients these drugs, they send them via mail. And when they restrict us from doing it, it is purely anti-competitive. So I really urge you to vote in favor for Senate Bill 513 so that we can best service these patients who really, really need that extra level of care, in addition to all the extra level of quality that we can really provide when we do this in-house. Thank you very much.
Thank you. Thank you for your testimony. Are there any questions in committee for this witness? Okay, seeing none, we will move on now to favorable with amendments, and we will hear from Kaylee Locklear.
Good afternoon, honorable members of the Senate Finance Committee. Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association. And I just wanted to make clear that the specialty pharmacies we represent are not owned by PBMs. There was something said earlier to that effect. Although we support dispensing of oral cancer medications in office for the first dose that will be used in conjunction with other therapies, our members had major concerns about a physician's office dispensing without a pharmacist there that is a drug expert, and what types of inspections and regulations the dispensing pharmacy would be subject to. For instance, our members are regulated and inspected by the Board of Pharmacy regularly for compliance, but we also believe that since these physicians' offices will now be dispensing both mail order and refills, their pharmacy should be regulated as such. And thus, we proffer what we believe are two friendly amendments, and we've worked on these a bit on the House side. One would be stipulating that the practice must have a pharmacist on staff that works a minimum of 20 hours a week. And then also explicitly stating that the dispensing physician pharmacy shall be regulated and inspected as all other pharmacies are. I'm glad to discuss further. I did reach out to the sponsor. And like I said, I've been working with the sponsor on the House side, but I look forward to working with you all on these amendments. Thank you.
Thank you, Ms. Locklear. Are there any questions for this witness from members of the committee? Okay. Seeing none, we'll now, I'm sorry, Senator Benson. Yes, Senator Benson.
Thank you. for the record, I'm a 35-year survivor, 35 years. Now, the question I want to ask of you, and by the way, had it not been for the kind of doctor that I had, I'm not so sure I'd still be here. But my doctor and the grace of God keeps me here. It keeps me going. Now, here's my question. The doctor has to prescribe the drug in order for the pharmacist to fill the drug, fill the prescription. So I'm just trying to figure out, why is it that you're asking that a pharmacist be with the doctor when the doctor is the one who says, this is a drug that I want my patient to take? That doesn't make any sense to me. The doctor has to be knowledgeable of the drug that he or she is prescribing, as in the case of my doctor.
So pharmacists are true drug experts, and they're going to be looking for counteraddictions and things like that perhaps a doctor is not going to be aware of. And so that's why we ask that there is a pharmacist there, and that pharmacy is also regulated for compliance with all of the other laws that exist regulating existing pharmacies, because they will essentially be acting as a pharmacy.
I'm missing something. That doesn't seem to register with me. My doctor is supreme. He knows exactly all. I could take I can take a prescription to him and he can tell me exactly what's in it and give me the X, Y, and Z. I don't understand why we need that pharmacist there with the doctor. I don't understand, but that's okay. Thank you.
Thank you, Ms. Locklear, for answering the question.
Thank you.
Thank you, Senator Benson. So I'll look again one more time to see if anyone else has any other questions for these witnesses. We will move on then to the unfavorables, and we'll start with Mr. Michael Johansson.
Thank you, Mr. Chairman. Mike Johansson on behalf of the Pharmaceutical Care Management Association. We oppose the bill. Let me first say this is not a pandemic-related piece of legislation. We've seen it in sessions prior. We have worked with the proponents of the legislation, and frankly, we find ourselves in the same place we've been in the last couple of years. They say that they have the ability to dispense drugs from the physician office, and they have contracts with carriers and PBMs. So what we're kind of confused about is, why does the bill mandate, that they are able to participate with every PBM or every carrier, which must be what it's trying to say. If they already have the ability to negotiate to be in the network with certain carriers and they adopt the rules and they adopt the payment, we don't simply see why this bill is in at all. It's amending the specialty pharmacy provisions of the law, which have been in place for many years, unnecessarily. What we see it is, honestly, is asking the General Assembly to mandate that every PBM or every insurance carrier contract with every physician office that wants to do this particular procedure. And honestly, we think that that's not the role of the General Assembly. If the bill's trying to do something else, and we've talked to the proponents, we haven't gotten to an understanding of exactly what it is that they're trying to do. And just as a final point, PBMs provide reimbursement for covered services, in this case, covered prescription drugs. We don't fill them. If there are specialty pharmacies, some of which can be owned by affiliates of PBMs, or as Ms. Locklear correctly stated, some are independently owned, some are actually owned by Maryland hospitals or other healthcare providers, those specialty pharmacies have to have a contract, and they're the ones who do the actual dispensing of the drug in accordance with exactly what the physician has prescribed. I heard this in the House, and I think I have to comment on it. There's a comment that a patient is getting a prescription drug delivered to them that they didn't want. A pharmacy cannot, whether it's by mail order or any other delivery process, send a patient a prescription drug unless the doctor has written a prescription for it. So if the doctors believe that there are drugs that are being wasted, it's incumbent upon them, when they learn about a new condition of their patient, to cancel an outstanding prescription order. So that to me is just kind of a little bit of excess that's been thrown into this conversation. We are working with the subcommittee in the House. Happy to work with the Senate Finance Committee if there's a solution that can be had. Thank you.
Thank you for your testimony. Any questions from members of the committee for this witness? Okay, seeing none, we'll move on then to Camille Fesh.
Thank you very much, Senator Augustine. Good afternoon, Sitting Chair, Mr. Vice Chair, and members of the committee. For the record, my name is Camille Fesh here on behalf of PCMA, along with Mike Johansson. And we are clear to be here in opposition to Senate Bill 513. A bit about PBMs. When a person pays a premium, it's usually through a large end, it's for the insurance premium. It's because the employer usually, or the state of Maryland, or perhaps a plan run on the government, like the healthcare exchange, the premium goes towards two entities. You have a health insurance company and you have a pharmaceutical drug insurance company. And as Mr. Johansson said, the PBMs pay reimbursements for pharmaceuticals that are prescribed by a doctor and filled by a physician. So the PBMs themselves never touch the drugs, do not own the drugs. They merely set the reimbursements for a patient and the copay. And they do that in conjunction with the large entity, the purchaser of the plan, usually an employer, or for example, the state of Maryland. So it's a thought out formulary plan that works across all drugs, all various types of conditions, across the entire plan and the pool of people in the plan. Here, the proponents have already stated that they do have medically integrated pharmacies. Those medically integrated pharmacies could become or may already be specialty pharmacies. And if they are, then those specialty pharmacies and the pharmacists that work within those specialty pharmacies would be able to distribute directly to the patient or via mail order to the patient the oncology drugs that are requested. So it's unclear exactly what this bill would accomplish or what actually the proponents are seeking to accomplish with this bill. I'm available for any questions if you have any. Thank you.
Thank you, Ms. Fesh. Any questions for the witness? Okay, seeing none, we'll go to our last witness for this bill and for the day, Mr. Matt Celentano.
Thank you, Senator Augustine and members of the Senate Finance Committee. My name is Matt Celentano, and I'm here today on behalf of the League of Life and Health Insurers in Maryland, which includes Aetna, Cigna, Care First, Kaiser Permanente, and United Healthcare. We are here in opposition to this bill. We're having a hard time figuring out why we even need this bill. It seems to actually create more problems than it's trying to solve. First and foremost, the bill is taking a pharmacy benefit out of your insurance and placing it into a medical benefit with a provider. We don't even know how the interplay of copays, benefits, premiums would work in this scenario. There's also no pharmacy oversight if it's taken out of the pharmacy and put into your medical provider. Frankly, it's just taking a square peg and trying to put it through a round hole. We also don't know if the doctors will have all of the drugs across the different formularies of the different carriers. This could limit consumers' options of care and create cost issues. There might be limited options depending on what they're having in stock. Physicians will most likely pick the drugs they have in stock to dispense, ones they can be reimbursed for, not what is best on the formulary depending on the carrier. Also, years ago, this committee and the committee in the House passed the gag rule, which enabled pharmacists to discuss cost options with consumers. Physicians won't have that line of sight to the different cost options that were created and what is the real value of the gag rule was. One example would be like my wife goes, or I'm sorry, pharmacists, without the benefit of the pharmacist, you might not be able to see across the different lines of what kind of drugs the patients are taking. For example, like my wife goes with my 82-year-old mother to go to every one of her appointments because she can never remember what drug she's taking. So there are real world implications to this. But maybe the basic question of all is why do we need physicians to dispense by mail anyway? Every specialty pharmacy is doing it already, especially during COVID. And why would their specialty pharmacy mailing be better than ours? It doesn't make any sense to us. If this was such a crucial patient issue, the provider should just get the pharmacy license and join the networks. That's all they have to do. And lastly, and the majority of the oncologist practices already have specialty pharmacies. They're in-house. The proponents already testified to it before. If that's the case, and they've already said that, the patient can literally walk down the hall and get the prescription. We just don't understand why this bill is needed, and we ask for an unfavorable report. Thank you.
Thank you, Mr. Celentano. Are there any questions for Mr. Celentano or any of the witnesses on this bill, Senate Bill 513? Okay, hearing none. That was our last one of the day. Vice Chair, you want to take it back over?
Thank you, Sarah Augustine. So we got finished at a respectable time today, and enjoy your evening. And it's not even 3:30, and we'll connect tomorrow. So do I hear a motion to adjourn for this afternoon from somebody?
Yes.
Okay.
So moved.
Motion from Hershey, a second from Senator Benson. All in favor, raise your hand. Okay, I see all. Okay, see you guys.